Hello and welcome to this presentation on oral cancer agents in the ambulatory oncology setting. Today we're going to review the evidence, look at our practices, and try to find solutions on how to best care for our patients that are being treated with only oral agents. My name is Carly Viola and I am a clinical nurse here at the Massey Cancer Center. In the specialty of ambulatory oncology, we are a rapidly changing environment. There is an increased pressure for hospitals to figure out what types of interventions and treatments must be given in inpatient setting versus those that can safely be moved to the outpatient setting. The outcome of this shift has led to a distinct increase in the acuity of the patients we see here in the ambulatory cancer center and in the patients we are treating. That leads to having an increase in educational needs for our nurses and more precise guidelines on how to care for our patients with these new and advanced therapies. In addition to patient acuity changing, the therapies themselves being offered for their patients are also evolving. In the past several decades, options for many different types of cancers as oral agents in the second and first line therapy has risen tremendously. Overall, there's an increase in new approvals of oral and subcutaneous agents for the treatment of cancer and a distinct decrease in new approvals for traditional long intravenous infusion types of treatments. Everything needs to be faster, quicker, and more efficient these days. Our drugs are becoming just as fast and efficient as we are. Here at the Massey Cancer Center, we are fortunate to be a National Cancer Institute designated comprehensive cancer center. What does that mean? That means that we have the ability to offer our patients the latest drugs, offer them broad access to clinical trials, and specialty services to treat very rare cancers. Every day we are offering more and more of our patients oral agents for the treatment of their disease, and this is wonderful for them. There are several benefits that accompany this new change in cancer medicine options. Our patients have more autonomy. There's decreased time spent in the clinic, a decrease of invasive events such as phlebotomy, accessing central lines. Those can lead to increase in infections. Despite all of these noted benefits, cancer centers must be wary of the barriers that accompany the increased use of oral chemotherapy. It decreases the time we get to spend with the patient. And if we're spending less time with the patient, then our assessment, our follow-up, those can all be at risk to not assess what's been going on in the patient in a timely fashion. Plus, nurses use that infusion time that we traditionally have spent with our patients to follow up on questions that they might have, to build rapport, and provide continuous education to assist the patients in managing their disease and treatment side effects. We don't have a strong connection between the home and the clinic, and we need to build one. The impact of this problem is quite large. Cancer centers need to adapt their policies, their insurance authorization process, and the staff education to include updated therapies. As pharmaceutical companies advance their technologies to replace more and more intravenous therapies with oral and subcutaneous ones, so must our cancer centers advance their own practices, their own policies. Patient education, side effect monitoring, and adequate follow-up care are all major hurdles that must be addressed in the setting of the oral and subcutaneous cancer treatment plan setting. The Oncology Nurses Society has conducted national surveys and shown that only about half of cancer centers currently have a policy that guide the practice of treating patients with oral agents. Furthermore, even where policies are in place, the processes that guide nursing practice are limited and do not fully encapsulate the time, the role, and the follow-up that the nurse needs to take with our oral cancer chemotherapy patients. The time it takes to educate the patient to understand a complementary regimen, how to take their medicine. Is it have to be given on an empty stomach, on a full stomach, with food, without food, at a certain time of the day? What happens if they forget a day? Are we checking their complete blood count? Are we checking their liver enzymes? If so, how often? There's so many considerations that must be taken care of, and the nurse needs to have full ability to manage that patient and their questions and their treatment plan. The research on oral chemotherapy is rather impressive. Consistently, evidence shows that oral agents can replace intravenous agents for the treatment of certain cancers with equal or even improved efficacy. One example is seen with the oral agent ixazomib, which is also known as Ninlaro, for the treatment of multiple myeloma. Ninlaro provides longer progression-free survival, overall survival, and a complete response and very good partial response. Increases in all four of those categories compared to the standard oral treatment of lenalidomide plus dexamethasone. Furthermore, research shows that adherence is a continuous barrier to access in the treatment of oral agents. Maybe patients are taking it, but they aren't taking their agents properly, or they are underreporting their symptoms so that they can stay on a drug that is potentially causing great toxicity to them. In order to increase adherence, evidence supports many different protocols to educate patients, follow up on their care, and validate their compliance with their oral regimens. One example was published in Oncology Nursing Forum and detailed a time-efficient, nurse-led program to increase patient education and adherence to oral chemotherapy regimens. Safety and frequency, time assessment of side effects for appropriate dose adjustments, those all enabled the patient to successfully remain on the oral drug with a tolerable and acceptable profile of side effects. Technology is the form of electronic information systems that guide our daily workflow as providers and nurses here at the Cancer Center. Our schedules are on the computer, our follow-up appointments, all of our diagnostic information, our clinical documentation, everything that is there in the electronic health record. Therefore, we need to adapt the electronic health system to include technological updates that facilitate a telehealth working environment. We are seeing these patients less and less, so we need to have connection with them outside of the clinic. We need to have an electronic way to communicate with our patients that is reliable, safe, and private. In-person assessments and monitoring are being replaced with secured email communications, video conferences, various applications, and the need for a telephone triage will continue to replace the need for in-person follow-ups. Based on the existing body of knowledge, identifying what our gaps in care currently are and what our goals are to increase patient safety and improved outcomes, there are 3 phases to working towards optimizing patient care of those on oral cancer agents. First and foremost is patient education. Patients who are started on oral agents must receive a scheduled educational session. This session is vital, and we need to set a culture of learning and show that the patient's primary goal of that educational session is to exchange information, validate knowledge, and ask questions. This session should absolutely be separate from a follow-up visit so that the patient and the caregivers are not distracted by all the clinical information they receive at their doctor's visits. The second phase is telehealth follow-up. Each patient on oral cancer therapy is prescribed a set of parameters, determines the frequency and timing of their follow-up triage phone calls. Things that could impact their frequency and timing of those phone calls might be pharmacokinetics of the treatment, the patient needs, and the nursing judgment. Maybe some patients only need a quick, hey, don't forget you're doing this, that, and the other, but other patients might need daily phone calls. They need daily follow-up. Hey, I know we talked yesterday, you've been working through your nausea, how's that going? Were you able to take your Ninlaro today? If so, how did you take it? At what time did you take it? Is everything okay? Those telephone triage follow-up phone calls are going to be essential to patient adherence, which leads us to our final solution phase, which is tracking of adherence. It's not enough to just say the patient is adherent. We need to be able to track just what adherence really means for us as an institution. It cannot be known unless it's tracked. Every patient encounter, either in person or through telehealth, must be confirmed that patient adherence is validated, understood, and properly being executed. There are, of course, ethical considerations with any new change or any new process. And in the setting of oral chemotherapy, our primary ethical concern of our practice pertains to the ethical principle of beneficence or doing good. Our practices and policies must reflect a constant goal of improving patient safety, patient outcomes, and patient satisfaction. A culture change from merely prescribing a medicine to prescribing an entire treatment plan should be resulted from the changes in practice and policy of oral cancer agents. It's not just a pill, it's a treatment plan, and we need to encourage and collaborate with our patients, with our caregivers, and have them understand that we expect a culture of patient safety. One major consideration regarding ethics is medication errors as they relate to oral chemotherapy. And this is when we really need to align ourselves with our pharmacy colleagues. Pharmacists are certainly our allies when it comes to medication safety. And the research on pharmacy-led collaboration to help prevent prescribing errors, specifically in the setting of oral agents, has shown to be very effective in decreasing errors and making sure the patients are taking the proper dose for them, for their treatment, for their disease. Everything has challenges and barriers. We have to acknowledge them so that we can move past them, so we can grow from them. Research shows that there are numerous internal and external influences from the patient that impact how compliant they are with their oral chemotherapy cycle. For example, patients that have high comorbidity of clinical depression, those who experience excessive nausea and vomiting as a side effect of their oral agent, and those with very high out-of-pocket copays were all negatively associated with proper compliance with their regimens. And you can definitely see why. If they can't afford it, they can't get it. If they're too sick to take the medicine, they will not take the medicine. And if they're so depressed they can't get out of bed, what makes you think they're going to take a pill for you just because you really asked them very nicely? So we need to be assessing, following up, educating, all of those things to help our patients get through those troubles to make sure they're treating their cancer the best way we can. In addition to those barriers to access of oral agents, nurses need a standardized assessment model to make sure that the way we assess for adherence is uniform for every single one of our patients. This is our conclusion. To reinforce a few of our main points, we have a plethora of evidence that helps direct our practice, and we as an institution need to develop some policies, procedures, and guidelines to help reflect that current evidence. We have to have a training module for physicians and nurses that in turn turns into training of our educating of our patients and caregivers to make sure that they're being as safe as they can with their oral agents. Thank you very much, and we'll open it up for some questions.